Assalamu alaikum. I want to present very important topic. Topic name is spinal chordoma. And before I am presenting, definitely I want to talk. I want to explain and means. Uh, when I try to explain this case, I want to present one analogy. But before the analogy, I want to talk about little the chordoma, and now I want to show you about chordoma. Before starting to this topic, I was thinking that I should show the chordoma. So on internet, when I am trying to search this topic, so and I want to present, then I found these pictures, and these pictures are very well explain. The chordoma is how means you can see this chordoma how extensive and large and area of presentation, involvement of the spine, and this is in the thoracic area how it is behaving. And definitely I will talk about more about definitely the spinal chordoma. And here you can see in this picture from the T2 to T4 this chordoma is extended, and you can see it is the rib one first and second rib behind that it is and you can appreciate. And roughly you can see this is the hemiclass shell here, and till fifth rib space you can visualize that. And you can in this picture you can see this is the chordoma posterior to the pleura, and posterior to the pleura how it can be seen and how it can be appreciated, and how we are approaching behind the pericardium and everything. So this was just I want to present and to give us a pictorial introduction. Now I will give you the introduction of this tumor. So the chordoma is a slow growing, or the we can say the low grade but locally invasive and locally aggressive tumor. So the chordoma belongs to the sarcoma family, and a sarcoma family of tumors, and they arise from the remnant of the notochord and occur in the midline along the spinal axis from the clivus to the sacrum and anterior to the spinal cord. And the location distribution of the chordoma is 50% in the sacral area, 35% in the skull base, or we can say the clival area, and the 15% occur in the vertebral bodies of the mobile spine. You can say the most commonly at the cervical two vertebra, and followed by then the lumbar and then the thoracic area. So overall 5-year survival rate is approximately 50%, and the treatment is an en bloc surgical resection followed by the high dose, and we can say the conformer radiation therapy such as the and proton beam radiation therapy. And regarding, if I want to say about little bit the an etiology, chordoma arise from the notochord, and the notochord is the mesodermal structure in the embryo, and which serve to help the signal tissue for the organization and the differentiation. And the notochord ultimately becomes the nucleus pulposus in human as it regress. And the genius implication in the, we can say, the chondroma formation include the, we can say, the brachyury gene, and the, we can say, mechanistic and a target of the rifampicin signing pathway or phosphatase, or we can say the tensin homologue and a gene deficiency, or INI1 or platelet derived growth factor receptor beta along. And although no definitive genetic marker has as of yet been identified, so there are currently a few reported familial clusters of the chordoma. And the chordoma typically affect those in the 40 to 60 years old age group. but have been reported in children, and the very elderly, most believe males are more commonly affected than the female in approximately 2 is to 1 ratio, with the annual incidence 1 in 1 billion for new diagnosis. So the chordoma account for approximately 20% of the primary spinal tumor and only 3% of the all bone tumor, and the most common location is in the sacral area or sacrococcygeal area. It means the 50%, and followed by 35% located in the occipital region, and the remaining chordoma about 10 to 15% located in the mobile spine, and the chordoma present with the slow growing locally invasive tumor with distant metastasis are rarely occurring and only late in the disease, although they are considered indolent tumor, and there is a significant risk for the multiple recurrence locally. So, if we are thinking regarding the history and the physical examination, the patient history and the physical finding are dependent on the specific location of the chordoma, and the skull base and the clival chordoma typically present with the headache and or cranial nerve dysfunction, and most often cranial nerve, we can say the sixth cranial nerve or the abducent nerve, although the lower cranial nerve can also be affected, and rarely a clival chordoma will present with the rhinorrhea due to the cerebrospinal fluid leak, and the cervical chordoma typically present with the non-specific neck, shoulder or the arm pain, and occasionally dysphagia due to the mass effect. So the cervical chordoma can also invade cranially to cause local cranial nerve dysfunction as well as compression of the spinal cord or exiting nerve, causing myelopathy or radiculopathy respectively. So the thoracic and the lumbar chordoma also present with the non-specific local pain and also may be the cause of the pathological fracture or radiculopathy or myelopathy, and the sacral chordoma share a similar and a presentation as the thoracic and the lumbar chordomas with the localized pain and the possible radiculopathy as well as possible dysfunction of the bladder, bowel and the autonomic nervous system, and if the tumor involve the lumbosacral plexus. So the evaluation, for the evaluation, we must know that the evaluation of chordoma revolve around the imaging and the biopsy. The plain X-ray will demonstrate a local destructive lytic lesion, and the computerized tomographic imaging is better for demonstrating the destructive lytic chordoma. Occasionally the chordoma will have the sclerosis at the margin, and chordoma are the hypodense compared to the bone on CT and may demonstrate irregular dystrophic calcification, and the chordoma demonstrate moderate to significant enhancement in contrast CT imaging, and magnetic resonance imaging best delineate the extent of the chordoma, and chordoma have a lower signal intensity in T1 weighted imaging and may show foci of the hyperintensity which represent intramural hemorrhage, and T1 weighted imaging with the gadolinium contrast demonstrate the heterogeneous contrast and the enhancement of the tumor with the honeycomb appearance, and on T2 weighted imaging chordoma tend to be hyperintense, and the gradient echoes of the MRI imaging can confirm intratumoral hemorrhage, and bone scan are sometimes obtained during the workup, and the chordoma have normal to decreased uptake, and many times a needle or the open biopsy is performed to confirm the diagnosis of the chordoma. Care need to be taken when planning and performing the biopsy, as the chordoma can seed along the biopsy tract, and thus the biopsy tract should be included in the future chordoma resection to decrease the risk of the local recurrence. I want to present this case in front of you. You can see this is the radiological picture of the MRI on the T1, T2 sagittal plane, and you can appreciate in the L3 area, you can find there is a on the, first of all I will tell you about the T1 image, and which is showing on the, it is a low intensity signal in the T1 weighted image, and this is the chordoma, and it is involving the, we can say, the anterior part of the spinal canal. As I mentioned that it is usually anterior to the spinal cord. And in the T2 weighted image, you can see there is we can say that with the hyper intense signals we can appreciate. So because of the edema, and you can see in T1 weighted image sagittal, you can appreciate there is a, maybe these are the some or the bleedings here, and which maybe that represent. Now I want to mention here, this is the post-surgical picture, and how this is the CT scan, and we can say the sagittal, or we can say the 3D reconstruction of the means survive of the lumbar. And here the total corpectomy has been done, and then you can see there is a cage has been placed, and with the four screw up and the four screws down, and to stabilize the lumbar spine for the treatment of the, and as I mentioned, the en bloc treatment is the treatment of choice for the chordoma. I can understand this picture when you see, and you can understand, which is showing or telling the 1,000 words by itself. I don't have to tell you more, but you can appreciate in the T2 weighted image a sagittal plane MRI, which is showing here. There is roughly, if we count from the 5, 4, 3, 2, between L1 and L2, there is a disk space, and this space is very much destructive. As I mentioned you that the chordoma is a rare, slow-growing, malignant tumor that develop in the spine and the skull base, and it is the remnant of the notochord, or the preliminary structure present in the developing baby in the womb, and it is the mesodermal tumor. And the exact cause of the chordoma has not been established with certainty, but people are telling, as I mentioned in my lecture, that maybe there is some factor, or some gene implication may cause this. So the most evident sign of the chordoma are the pain and the neurological changes, symptom typically with the headache, especially in the head area, and then if the spine involved, then the radiculopathy and the pain, and definitely if involved in the head more or skull base, then definitely the double vision and the vision problem, and if it is in the neck region, then the symptoms are different. So according to the area it present with the, for example, I just show you at the L1 L2, and definitely present with the pain and the radiculopathy or the myelopathy according to the extent of the disease. So you can understand this. Now here I want to show you, there is a sacral area, and in front of the sacral area you can see the mass, and you can appreciate the width and the length. Definitely it is showing in the picture, and you can appreciate here the length and the width in front of the sacral spine, and you can appreciate that it is the huge chordoma you can see, and definitely present with the pain and the radiculopathy, and involve the nerve, and causing the pressure over the nerve. So and treatment, definitely for the treatment, there's a treatment which provides a longest survival is complete en bloc resection of the tumor with clean margin, and this can prove the challenging either due to the location of the chordoma or the reconstructive need after the resection. And intratumoral resection and the piecemeal resection may also provide a similar benefit if complete chordoma resection can be achieved without local seeding. So then local debulking is sometimes advocate. If complete resection is not technically feasible, then the local debulking can and alleviate the symptoms secondary to the mass effect, as well as provide a smaller target volume for future radiation therapy. And the most physicians advocate for the radiation therapy and after any type of chordoma resection due to the high local recurrence rate, and chordoma are relatively radio resistant and necessitating the high dose radiation therapy, as chordoma are found near neuronal structure. So the highly conformal radiotherapy is used and includes the proton beam radiation or the radiosurgery. Conventional photon radiation is currently thought to be of the no benefit to chordoma patient, and the slow growing nature of the chordoma make them resistant to most current conventional chemotherapeutic agent. And if the chordoma is treated with the chemotherapy, then the treatment typically occur within a clinical triad. And due to the high local recurrence of the chordoma, most physicians recommend the lifelong surveillance with the magnetic resonance imaging with and without gadolinium contrast. And the metastatic chordoma should be on the differential if new lesion erased elsewhere in the body, as up to 20% of chordoma can metastasize. So the differential diagnosis here, the clival spheno-occipital lesion and the benign notochordal cell tumor or the chondrosarcoma or the chordosis, or we can say the meningioma or the pituitary macroadenomas or the plasmacytoma, or the we can say the vertebral lesion if we are considering, then definitely the chondrosarcoma, giant cell tumor, plasmacytoma, spinal metastasis, spinal lymphoma. So these all are very important to understand, and the differential diagnosis is much important because you have to understand according to area the differential diagnosis you have to understand, such as if the clival is spheno-occipital lesion, then you have to understand that the benign notochordal cell tumor and the chondrosarcoma or chordosis, or we can say the meningioma or the pituitary adenoma or the plasmacytoma. But if we are considering the vertebral lesion, then we have to understand that the chondrosarcoma, giant cell tumor, plasmacytoma, or we can say the spinal metastasis and the spinal lymphoma. I want to show here a very interesting picture regarding the treatment because I already presented the treatment here, and this picture will say the 1,000 words in front of you. In this picture, A, B, C, D, E, F, and G. You can see there in A, you can appreciate the how much, what is the extent of the disease, what was the extent of the disease, and what is the extent of the fixation in the AP X-ray, and you can see there in the lateral view, which is showing by the figure B and which is showing there the cage placed already, and you can see there is that there is a 4 screws below and about a 6 screw I can see here above, or maybe more, but here in the other C picture you can appreciate here there is maybe the 10 screws above, and then the cage we can see here in the picture C, and then the 4 screws below, and here which is I think the picture of this thing, the same, the D is also suggestive for that, which is showing that there is maybe the 10 screws, or maybe we can say the 14 screws above and the 4 screws below to stabilize the spine. And if you see the G and H, the same story they are telling. So these are detailed X-rays I just wanted to present in front of you. Sometimes we have to, for the treatment, we have to do this kind of surgery after the en bloc resection. Few important thing I want to talk about this topic. Actually, it should be stressed that if chordoma is entertained in the differential diagnosis, and then there should be careful planning for any biopsy, or as the biopsy that tract need to be included in the ultimate resection of the chordoma to decrease the risk of the local recurrence. So despite the local or the low grade status of the chordoma, they have a high recurrence rate and significant mortality. So the 5-year survival is approximately 50% overall, but improved with the complete resection with a negative margin to 65% 5-year survival rate from the 50% to 65%, and then surgical resection with positive margin is approximately 50% 5-year survival rate. So if the chordoma is inoperable, 5-year survival is approximately 40%, and that macroscopically chordoma are soft and we can say the gelatinous tumor and may have hemorrhagic presentation, and microscopically they consist of the fibrous septa and separating lobule of the, we can say, the bubbly cell with an, we can say the extensive myxoid stroma and rare mitotic figures. So the chordomas can be divided into 4 subtypes, and conventionally we can say the poor differentiation, dedifferentiation, and chondroid. Conventional classic chordomas are the most common variety and may show areas of the dedifferentiation, and the poorly differentiated chordomas are more common in the young adults and the pediatric patient, as well as the skull-based chordomas. Poorly differentiated chordomas shows a loss of gene INI1, or dedifferentiated chordoma typically are the fastest growing and the most aggressive chordomas, and can also have a loss of INI1 and are more common in pediatric patients. And the or we can say the chondroid chordoma describe chordoma that are typical to distinguish from the chondrosarcoma on histology, and typically then we can say the chordomas express the gene and brachyury, and whereas the chondrosarcoma do not express the brachyury gene, and the or the chordoma have been reported to differentiate into the high grade spindle cell tumor, which portend we can say the worst prognosis. So here actually I want to tell you the enhancement healthcare team outcome or the management of the chordoma is the best done with the interprofessional team that includes and the orthopedic surgeon, radiologist, neurologist, and the pathologist. So depend upon the location, other specialties may be involved like the neurosurgeon, oncological nurse, or we can say the pediatrician and the ENT surgeon. And the chordomas are locally aggressive tumor, and wide en bloc resection is the ideal treatment, and nurses are involved in the perioperative care, recovery, and the rehabilitation. So they monitor patient status and educate patient and their families, and update the rest of the team. So the pharmacist review medication, check for the drug interaction, and provide education too. So the oncological specialty pharmacist can assist with clinical trial selection if chemotherapy is considered. So the recurrence are common, and in some cases the tumor may degenerate into aggressive cancer. Here I want to present one case for the analogy to make understanding more clearer for all of us here, that there is a one patient with me. I treated her, which is a 65-year-old female, and presented with the 3 weeks of the mild low back pain and the urinary incontinence and numbness, tingling in the saddle region, and she denies weakness and bowel incontinence. Her symptom persists despite the treatment of an otherwise, we can say, the asymptomatic UTI and the normal strength throughout. So and you can see reflexive was +2 in bilateral lower extremities, and decreased perianal sensation, and normal rectal bone and negative Babinski and the Hoffman sign, and the differential diagnosis here definitely comes in my mind there, that the degenerative scoliosis or the compression fracture or the disc herniation or the quadratic vena syndrome. If I going for the neoplastic lesion, then maybe the metastasis or the extradural tumor such as the chordoma, aneurysmal bone cyst, plasmacytoma, and the intradural extramedullary tumor such as the meningioma and the neurofibroma, or the intramedullary tumor such as the ependymoma and astrocytoma. So the vascular lesion could be the AVM or the cavernous malformation, and the infectious maybe because of the diabetes, and maybe because of the IV drug use, or maybe because of the immune deficiency, and the discitis or the osteomyelitis or the epidural abscess. And then I did the CT, and then I did the MRI of the lumbosacral region, and I found in the T2 weighted MRI demonstrate and the abnormal hyperintense mass in the distal spinal canal sacrum and adjacent soft tissue, and the mass is further emphasized on the coronal T2 MRI and demonstrate the anterior extension to the sacrum and into the adjacent soft tissue. So the further workup then I did for the CBC and BMP and the PTINR and the APTT and the ESR and the CRP and the prealbumin and the procedural radiology done definitely. And as I mentioned, I did the CT of the lumbar spine, abdomen, and the pelvis to evaluate the bony involvement for the pre-surgery planning, and the systemic metastasis is frequent here, and the contrasted pelvic MRI to evaluate for other potential malignant etiology seeding the spine and for the preoperative planning. So the contrast MRI of the neuroaxis to rule out the metastasis to other central nervous system region. Procedural radiology, such as you can do here the biopsy to confirm the diagnosis of the chordoma when the chordoma is suspected. So the great care must be taken to prevent seeding. For this reason, transrectal biopsy are contraindicated, and ideally biopsy tracts are made to facilitate their resection if the chordoma is confirmed. Consultation here needed, definitely internal medicine, pre-operative evaluation. And if you know the pathophysiology of my case, if I want to explain, it's not easy to understand because few things such as the chordoma are a malignant neoplasm and resulting from the embryonal remnant of the fetal notochord, and the fourth most common malignant tumor of the bone, and it comprises approximately 1 to 4% of the primary bone tumor, and there is 2:1 male to female preponderance, and the chordoma manifests most commonly in the sacrum 50%, as I mentioned before, and the spinal and in the spheno-occipital area 35%, and the cervical region 10%, and rare area is the lumbar and the thoracic area 5%. So given the large volume of the sacrum and adjacent cavity, so the patient often remain asymptomatic until we can say that the substantial tumor growth within the pelvis has occurred, and the symptoms can develop or include the urinary incontinence, bowel dysfunction, and the weakness. But the most patient present with the lumbar and the buttock pain and the disease recurrence and the local metastasis are aided by this tumor tendency to form a pseudocapsule with satellite lesion which may be released by the surgical manipulation. And the key histopathological features of these tumors is the presence of the, we can say, an Physa lephurious cell, or which is also called the bubbly cell, and the histopathological feature. These are the histopathological features of the chordoma. Treatment option, as I mentioned here before, but I want to, because present again for my analogy case, because the medical back pain, NSAID, and the oral corticosteroid and muscle relaxant are important than the radicular or the neuropathic pain. For the neuropathic pain, we can give the gabapentin and the pregabalin and the antidepressant, and the chemotherapy is rarely indicated as stand-alone therapy in chordoma, and dedifferentiated tumor may have a higher rate of the response. So identification and targeting of the stem cell like the component of the chordoma may prove useful in future studies, and the mechanical such as the physical therapy, activity modification, muscle strengthening, optimizing posture, and the mechanism to limit sacral loading. And there is the radiation therapy. Chordoma tends to require the high dose radiation treatment for disease control and resulting in a tissue injury to the spinal cord and other adjacent tissues, and the adjuvant therapy is indicated in some patients with the positive resection margin and the inoperable tumors or the large tumor burden, and the protein beam is particularly effective here. So the surgical, the chordoma tend to require the high dose radiation therapy for the disease control and resulting in a tissue injury to the spinal cord and the other adjacent tissue, and adjuvant therapy is indicated in some patients with positive resection margin but inoperable tumor or the large tumor burden. Proton beam is particularly effective but not that effective as we are thinking. Posterior approach and secretectomy actually the less invasive and the single stage approach that does not require assistance of the general surgeon, ideal for the smaller tumor, but are the predominantly posterior in extension and caudal and preserve more function, but may result in the higher rate of the local recurrence in case where the encapsulate component are not completely resected. So the lack of visualization and the translation of the visceral organ may increase the risk of the injury during osteotomies. So the combined anterior and posterior approach, secretectomy, more invasive two-stage approach that is the best performed with assistance by the general surgeon for the laparotomy, and then for the protection of the visceral organ via dissection and the movement outside the planning means the planned resection trajectory and the sacrifice of the sacral nerve root may be necessary sometime and requiring a fecal direction via and a fecal diversion via on ostomies, and the risks are higher because of the additional surgical procedure but increased ability to obtain negative resection margin and ideal for the large or the rostral tumor. So here I want to present you there is a surgical technique for the anterior, posterior and sacretectomy. Actually, is supine position with the neuromonitoring and fluoroscopy. For localization, the anterior approach exposure is performed with the assistance of the general surgeon. Once completed, an intraoperative imaging is used to confirm the sacral level, and the intraoperative X-ray, we have to localize the posterior aspect of the S1, and then the high speed drill is used to perform the osteotomy to achieve the partial osteotomy and allow for removal of remaining bony structure posteriorly, and in this vignette S1 and S2 hemostasis is achieved and the wound is closed with the general surgery assistance, and the patient is transferred to the prone position and an appropriate level confirmed. Then subperiosteal dissection is performed at the L5 to the coccyx in this vignette, and the laminectomies are performed with care take to expose the end of the thecal sac, and the lateral margin of the sacrum is identified and dissected further into the soft tissue depending upon the tumor spread, and the coccyx is dissected free of the soft tissue attachment, and the bowel is identified to ensure its preservation. the sacral nerve are identified and followed by the osteotomy site, and the release of entangled sacral nerve is performed. And the osteotomies continue posteriorly until sacroiliac joint sparing sacroiliacectomies has been achieved, and the specimen removed as once, and the tumor outside the sacral boundaries is resected until 1 to 2 inch of the normal tissue is observed. Obtaining the negative tumoral margin is an important prognostic indicator in preventing recurrence and the maximizing long-term surveillance, but intraoperative rupture of the capsule greatly increase the risk of the recurrence and reduce long-term survival. So the review of the pelvic anatomy and the preoperative imaging is crucial to planning the negative resection margin. The sacroiliac joint from a barrier that reduce tumor spread, and the resection of the joint allow for the greater dimension intraoperatively into adjacent viscera and musculature. And when necessary, partial or total resection of the sacroiliac joint should be preceded by the consideration of the need for instrumentation to prevent instability, and care must be taken to identify uninvolved visceral or neurological structure. However, tissue in which chordoma has grossly invaded must be resected aggressively to prevent local recurrence. So care must be taken to identify the uninvolved visceral or neurological structure. However, tissue in which the chordoma has grossly invaded must be resected aggressively to prevent the total or the local recurrence. And the sacroiliac joint from the barrier that reduce the tumor spread, and resection of the joint allow for the greater dissemination intraoperatively into adjacent viscera and musculature, and when necessary, partial or total resection of the sacroiliac joint should be preceded by consideration of the need for the instrumentation to prevent the instability. I want to tell you one last thing here, and then we will conclude our lecture here, that all sacral chordomas, when we are resecting by the only posterior approach and preoperative immobilization, so the skin incision were either the transfer or longitudinal, or we can give the inverted Y incision, and these all are appropriate. And superior part of the dissection was at the lumbar level or the S1 posterior surface regarding the preoperative planning. And if the resection margin we can say with the S2 level, the superior dissection margin would not end at the S1, and on the other end the dissection would end at the L3 if total sacroiliacectomy should be planned. And the iliolumbar instrumentation definitely performed for the local transversectomy, and inverted Y, as I mentioned, the incision can be longitudinal, can be transverse, or can be inverted Y. One of the patient which I remember, which is 45-year-old male who present with the gut obstruction from the enlarged tumor arising from the pelvis, and the exploratory laparotomy, diverting colostomy, and the subtotal excision debulking was performed by the abdominal surgeon in 2015, and the remaining mass was enlarged, and 3 years later the patient was referred to our department, and we performed the second surgery and S3 sacroiliacectomy with the tumor removal in 2018 by the posterior approach, and no serious complication was encountered, only the large seroma which gradually resolve because there's a big cavity need to fill and take time, and these seroma can give you or irritate you, and so the no recurrent tumor was detected throughout that time. So this is the few things I want to mention in front of you. In recurrent chordoma, we can use the previous incision if we can see, and the recurrent mass should be identified and excised with the bony attachment, and again, and the reconstructive procedure should perform, and total sacroiliac joint reconstruction procedure we can do, or the fixation procedure we should do, and in primary or the subsequent resection if the tumor is ruptured or spilled, so the copious amount of normal saline irrigation should perform for decontaminate the tumor as much as possible. I think I tried to explain here in detail, and definitely this is and definitely when we are talking about the spinal chordoma, definitely the lumbar areas are coming, the L2 and L4 areas are coming, and then definitely, and when we are talking about thoracic, then the T9 area are most involved, but these all are can be treated with the en bloc excision and then multiple fixation above and below. I hope I tried to explain as much as possible to you, and I tried my level best. I hope you will like it. If you like it, please subscribe, share, and support me. Thank you so much. I will try to produce more lecture like this, and I will try to bring some we can say the advancement in my lecture and clarity of voice as much as possible. Thank you so much. See you with another video. See you.